Let's go ahead and get started. Thanks everybody for joining today. We are here for the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Today is Thursday, September the 23rd. Thanks everyone. I hope you guys are all having a great day so far. So let's see here. On the phone or on the webinar with me today from STS, we have myself, Carol Crone, we have Addie Dolan. We also have from the STS side, we have Sydney Clinton from our STS surgeon leadership. We've got Dr. Jacobs on the line today. We've also got Chastity and Leslie from the core group, and Chastity is going to be providing some education for us today. From our IQVIA side, we have our usual suspects. We've got Jean, Joe, Melanie, Michelle, and Steve. So thanks everyone for joining today. Let's just go over briefly, cover the agenda real quick. Again, I'll just provide some very brief STS updates. I don't have a lot of new information to provide from our last call. And then, as I stated, Chastity will be providing a complications revisited session. So she'll take over the presentation shortly after I provide those STS updates. Then we'll turn things over to our IQVIA colleagues for their updates. And as usual, we'll end the session with you, with your user feedback, with your questions. Please submit your questions via the Q&A and not the chat box. Also, if you have a ticket number you would like IQVIA to look into, if you could, please go ahead and put that into the Q&A and provide that, that ticket number, that case number, and the support team can go ahead and start looking into that for you. And we'll be able to respond once we're done with the presentation today. All right, STS updates. Again, like I said, not much to cover from this end. The September training manual was posted and is available out on the website. The 2020 harvest analysis update, as we've stated, the data are expected to be released in mid-October. The dashboard UAT testing is winding down. Fixes are currently being implemented on the IQVIA side, and those are being retested prior to the release, prior to releasing all of that data to you all. So again, we're very excited. A lot of work has gone into this and a lot of hours and time being put into UAT. We greatly appreciate all of our core group members and the data managers, the beta testers and the UATers. We greatly appreciate all the time and effort that you have put into this UAT testing. Again, we appreciate your time and dedication to this database. As always, participants will be notified by the STS when this data is available within the IQVIA platform. We will be sending an email to you all directly, as well as there'll be a notification posted within the IQVIA platform. But again, we will send you all an email directly announcing that the analysis reports are available within the platform. And also, IQVIA is going to provide an educational session on the risk-adjusted dashboards functionality. We're going to go over that on the October 5th user group call. We're going to do that a little bit closer to when the reports are released. 2021 harvest update. Again, I do not have much information based on the last call. We have our task force call next week. This will be a topic of discussion on the call Tuesday night. So I'll have more information to provide you guys after that call. But as we stated earlier, we are having one harvest for 2021. The spring and fall 2021 harvest is going to be combined. Please continue using the open submission and cleaning your data. Obviously, we'll give you plenty of time heads up to get that any data cleaned up and resubmitted during the current harvest. Obviously, the 2020 analysis report will be released in mid-October. Give you ample time to review that, look at your data, clean up any data, get that data resubmitted for the 2021 harvest. So again, more information on that close date will be coming once the reports are released and we get proper feedback from you all. And of course, just a reminder that 2021 harvest will include procedures up through 6/30/2021. Also, just a friendly reminder, AQO is coming up very, very soon. Our congenital session is going to be on Friday, October the 15th. And just a reminder to everyone, since AQO registration is free for those contacts that hold one of these roles here, you will have access to all of the days. So even though you're a congenital participant, if you want to learn more about adult cardiac, general thoracic, INTERMAX, PDMAX, you have access to all of these days, not just one session, not just the congenital session. So again, we really do encourage you all to check out the other sessions. Also, we'll have some social activities. We'll also have a general session we would like you all to attend. So again, please check out the agenda and the schedule. All of this information can be found out on the STS website. And if Carol or someone from the team could just please put that a link to the AQO page out in the chat box, would be greatly appreciated. If you have any questions about AQO, you can please feel free to reach out to Emily Conrad. Emily can be reached at econrad@sts.org. Also, feel free, you can email me directly. If I can't answer your question, I'll either get you in touch with Emily or Amy if you need assistance with registration. All right, that's all that I have from the STS perspective for our update. So I'm going to turn things over to Chastity and let her take off at her sessions on complications revisited. Chastity, floor is yours.
Awesome. Thank you, Leanne. So I thought we would revisit some complications and give you some tidbits and information about the collection of complications in the database. And then at the end of this presentation, I have a few more things to add in, some things I've seen from data manager chats or what have been submitted as FAQs, and thought that this would be a good place to provide some feedback to everybody. Of course, these updates will make it to the training manual in the next few weeks. And so the next posting you see next month will have all of this information in it. So without reading this entire slide to you, I know you all know what the definition of a complication is, and it's actually much longer than this, but I pulled the kind of meat and potato part of the definition. And what you see is the word hospitalization. So if you go to the next slide, Leanne, you will see that we need hospitalization to be updated to refer to the episode of care. So for those of you who have been doing this for a while, you know that the database collected everything, including mortality, through hospitalization or within 30 days of the operation. We then morphed and I should say probably developed more along our continuum, and it became episode of care focused. So when this term was introduced to the database, a few harvests back, a couple of years back now, much of the training manual did not get updated, unfortunately, to reflect episode of care. Many of us started doing this work based on the episode of care because it is consistent then with how we define mortality in the database, and it's consistent if you were to be discharged to another facility and then come back to your facility. So you never went home and it's still during your episode of care, that you're still collecting those complications when the patient comes back to your facility. So this is a practice that I think we're all doing in some way, shape, or form, but it's time to update the training manual so that people are not confused. So it will be updated to say episode of care. Okay, so next slide. So a few tips for coding complications, and I know we've visited this before, but I'd like to just say it again, especially if you're new or need to hear it again, or your surgeons need to hear it again. You really want to think of complications as intra or post-operative events. So don't think of everything as this is a scorecard or badness against your program, surgeons, intensivists, anything. It's really describing the intraoperative and postoperative course of the patient. So it's events that occurred to the patient. It's not saying, you know, surgeon A, you're a bad surgery, or program B, you're a bad program. It's really just describing that post AV canal repair. These are the common events that maybe across the board, across all of our programs, that people are seeing. And so it's a way that we can continue to look at our patient populations and improve the care of these patients when all of our programs data is combined together and somebody takes a look at that. So there's no scorecard that says, gosh, Chastity in Phoenix, you have 10 complications after this procedure, and Leslie in Michigan, you only have 2. And so that there's no scorecard for this. So it's really describing the post-operative course. And that's why we see things like the sternum left open. I know I explain this ad nauseum to surgeons that there's no bad scorecard because you couldn't close the sternum, or that it was planned or unplanned. It's an event that happened that we want to know about and be able to look at later to see what we could do to perhaps prevent something like this. So 2, keep your training manual open. Every complication definition is different. And so some require you to not, that it be a new onset, a new finding. So such as renal failure needs to be new onset renal failure. Other things doesn't matter if you had it postoperatively or not. So always keep your manual open. There is no way that you can memorize the definitions of all of these complications. So timing, again, because each definition is different, sometimes the timing is slightly different for each of these. So I think of this in arrhythmias, and we'll revisit this in this presentation as well, but the arrhythmias that occur in the OR may be a little different than if they occur postoperatively in the unit. And so just being aware of the timing is important. And something like intraoperative or intraprocedural death isn't going to happen in the unit. And so again, timing is important and each one of them is different. Also note that complications will overlap. We know this, we've talked about this a lot, but I think it's a struggle sometimes for surgeons. So you're going to check 2 boxes and not just one. Yes, the complications do overlap in this data version. We're going to see some updates with our data version that will roll out next year where we won't see quite the overlap, but for now it is absolutely appropriate that complications will overlap. So in the instance that your patient has a cardiac repair, goes on to receive a trach, you will hit an unplanned non-cardiac reoperation as a complication, and also tracheostomy as a complication. So yes, that's an overlap. It doesn't mean you get dinged twice. It's not a double hit or anything like that. Again, there's no scorecard or sum of all of your complications. They are events that occurred. The patient had an unplanned non-cardiac reop and the patient received a trach. Okay, next slide. Oh, and let me just back up 1 second. You can stay on the slide, Leanne, that's fine. But how do you collect the information if your patient is transferred to another facility? So I think all of us do this differently. You're more than welcome to reach out to any of us that probably have some more robust processes in place. But some just basic ideas off the cuff, I would say if you are one of the lucky centers who has an EHR with the Care Everywhere and Anywhere option, that's always a great place that you can see when you've transferred a patient to another facility, what's going on at that other facility, or at least what's hitting through that mechanism. Another way to do it is, and this is what we do, is put it on your calendar. Like, you've got a patient that transferred to another facility, and call the data manager at that facility every few weeks. So I work very closely with another program here in Phoenix, and we call each other regularly. And I will give a shout out to Maggie because she's much better at this than I am. But she'll call me probably every 4 to 6 weeks and say, hey, we've got one. And we talk, every 4 to 6 weeks-ish and talk about what complications are occurring, or if the patient discharged home. So she has a database discharge date, or vice versa. I have a database discharge date at our facility. And so it really helps to get to know the other data managers if you're transferring to other hospitals. If it's not an acute care hospital, but say you always send patients to a more rehab type facility or long-term care facility, reach out, find yourself a friend in those places. And if you're calling them every few weeks, they get used to you. They know you're going to call. They appreciate your phone calls. And so just work out those relationships. So if you need more ideas, there are people that do this 100 different ways. And so, contact the core group or any of your friends here in STS, and we're happy to help you walk through this or talk through this if it's something new that you're not used to doing. Okay, cardiac dysfunction. We all know that this complication has caused us some angst, or we feel unsettled with it. I've seen the talk about asking for a more precise definition, or one that's closer to other databases that we use, or things like that. I will say that our surgeons within STS feel very strongly about how we collect cardiac dysfunction and cardiac failure. And so our definitions will be updated and tightened up a bit, but we're not going to flip to someone else's definition of cardiac dysfunction. So ours is a little more broad, I would say, than others, but hopefully we can get to a better place. So next slide. Okay, so really the intent of coding cardiac dysfunction and on to cardiac failure is that it's a continuum. You're going to start out in cardiac dysfunction, and then perhaps you could even move into, a continual failure or into cardiac failure, right, along that continuum. And so what the STS database is looking for is you need both cardiac dysfunction and a low cardiac output state. So in the absence of that cardiac dysfunction, so in the cases of hypovolemia and vasoplesias, these are not meeting the criteria of what we're looking for in STS of cardiac dysfunction and a low cardiac output state. So I know many of you have submitted questions to the core group, and I apologize that I know some of your answers are delayed, but they're coming to you because we've had lots of talks about this, lots of discussion, both in the upgrade calls, so multiple surgeons, as well as the surgeons who participate in our core group calls about this very field. And so we wanted to really help data managers refine this. So we're looking for the patients to meet cardiac dysfunction and a low cardiac output state. If you only meet one or the other, then you're not meeting this definition and you don't need to code it. What we will likely see in the future is perhaps a new field next year, version 6.22, that speaks to a low cardiac output state without evidence of cardiac dysfunction. And I don't know how that will look or how it will get added in at this point, but it is something under discussion. That way you do have something that you can check, but that the patient had normal cardiac function. Next slide. So other improvements, again, we're going to remove the hospitalization to be consistent, and it would be episode of care. And then also we do know that the definition has two conflicting statements in it. It says further up in the definition to code both cardiac dysfunction and cardiac failure should both occur. And then at the end of the statement, it says if they meet criteria for severe cardiac dysfunction, then only code the severe cardiac dysfunction. So I think when we look at this I can tell you how we got here. If we look at this from the perspective of this is a continuum, patients start out with cardiac dysfunction and then it worsens over time and they end up in cardiac failure or severe cardiac dysfunction. But what we also know about our patients is, and that's how we got the statement at the end. But what we also know about our patients is this can happen at different time points, right? So maybe coming right out of the OR, they had cardiac dysfunction, but then 3 or 4 days later, there's a cardiac arrest, the patient goes into severe cardiac dysfunction and ends up on ECMO and listed for transplant. And so now you have 2 different time points, after surgery where kind of 2 different complications occurred. And so that's where the conflicting statements ended up in the definition. And so I think that we're going to continue to allow people to code one or the other or both to address this. So you'll see that the last statement there, only code severe, will be removed. Next slide. All right, so for coding tips for cardiac dysfunction, and this really is based on some of the questions that have been asked. The criteria for meeting cardiac dysfunction is not dependent on the treatment. So obviously you can have a low cardiac output state, but normal cardiac function, but we're treating that with inotropes, with methylene blue, with volume. And so just because you receive these treatments does not mean you meet the definition of cardiac dysfunction alone. You have to see why, you have to understand why your facility or your intensivists are providing these treatments. Also, the consideration of expected and unexpected does not matter. So we know when you come off bypass and hit the unit, there's what we call the post-bypass slump, where we often increase our inotropes or give volume to these patients, and it's quote unquote expected in our minds. It's what we think is going to happen, and it does happen. It doesn't matter if your patient has a low cardiac output state in the setting of cardiac dysfunction. Whether it's an hour after the OR or 3 days after the OR, whether it's expected or unexpected, it's an event that occurred, and we want to go ahead and code that complication. And so again, that immediate post-op timeframe still counts if the patient meets the criteria of cardiac dysfunction. So the best ways that I think that you can capture this, and maybe a shift in how we think about the complications and how we're going to code them, is partner with your clinicians. Perhaps they can get better at documenting this. And I've seen documentation at some hospitals where they honestly say, this is low cardiac output with, normal cardiac function, and, is not in, this cardiac dysfunction state. And so if you work with your intensivists, they want clean data, as do your surgeons. They want to provide you with the tools that make your data most accurate. And so most of the time I would feel that your clinicians would be very receptive to you coming to them and saying, I have a very hard time discerning this based on our charting. What can we do to improve this? And so perhaps you can change something within your EHR, within their documentation, that they can make a statement as to whether the cardiac function is or isn't appropriate. Next slide. Intraventricular hemorrhage greater than grade 2. In the complication section, we were remiss and found out that noted, I should say, that there is no training manual or no definition included in the training manual. So thank you to the person that actually asked us a question about this. And when we went to look at the definition, realized there was not one. However, we have very nice definitions in our preoperative factors, and there shouldn't be any reason that those shouldn't be consistent. So we're going to bring over, since it's greater than grade 2, we're going to bring over the definitions from the preoperative factors of grade 3 intraventricular hemorrhage and grade 4 intraventricular hemorrhage. And so we'll see this populate in the training manual, and then we'll remain there for future use. But what I do want to point out is that this will include patients of all ages. So, anyone we're operating on that is being entered into the congenital database, if they experience a greater than grade 2 intraventricular hemorrhage, the complication should be captured, as well as we are not limiting it to certain imaging studies. So if you have a head CT, MR, or ultrasound where this has been diagnosed, then we're going to capture the complication. Next slide. All right, arrhythmias in the OR, we know over time that these definitions have been clarified, and I think sometimes with the clarification, it brings on more questions. So what we do know for sure for all the arrhythmia types, or all the arrhythmia treatments, I should say, is that we are not coding arrhythmias while you're on bypass, separating from bypass, or in the process of separating from bypass, or preparation to separate from bypass. So those we're going to discount, and that's not what we're looking for when we're looking for these arrhythmias. I'm only focusing on what's happening in the OR because it seems what happens post-OR in the units is probably pretty straightforward. It's really what happens in the OR. So if we look at arrhythmia requiring drug therapy, if the drug is given at time of separation from bypass and is discontinued or is resolved before leaving the OR, then don't code this arrhythmia. So again, if suddenly they start a drip while we're separating from bypass for an arrhythmia that the patient is experiencing, and they turn off that drip before the patient leaves the OR, then we're not going to code the arrhythmia requiring drug therapy. However, if that drip gets started around the time that we're separating from bypass and the patient transfers to the unit and they're still on that drip, then we would go ahead and record that. Arrhythmia requiring cardioversion and defibrillation, what we've seen here in some of the detail is that rapid atrial or overdrive pacing for a rapid rhythm is going to be included here and not under temporary pacing. And then arrhythmia necessitating a pacemaker or temporary pacing, you're only going to code this pacing if it is still present when the patient leaves the OR. So those are the clarifications that have been made here. Obviously, if you have any questions about any of these complications or any of the clarifications we've made, please continue to submit your questions to the core group. We know that sometimes it all seems easy on a slide, and then you get into your specific patient scenario and go, but wait, does something in my scenario make this different? So please, this is not meant to deny you from submitting questions to us. We just realized that we're getting quite a few questions regarding these past few applications I've discussed, and just wanted to put out kind of a broader information regarding them. So next slide. So I'm going to go through a couple scenarios, and many of these are based on the questions that you've submitted. So thank you for providing me with my content for these slides. So in this scenario, before skin incision, the patient experienced an arrhythmia during line placement that resolved following an amiodarone bolus. So do we code the complication of arrhythmia requiring drug therapy? And the answer here is yes, because the arrhythmia was treated with a medication or a drug, and the arrhythmia occurred prior to the insertion of the bypass cannula. So remember, we're not going to collect any arrhythmias that occur while the bypass cannulas are present or during the removal of the bypass cannulas or we're coming off bypass. Next slide. Patient discharges to an acute care facility for extended recovery following a cardiac repair. While there, the patient experiences a pleural effusion and receives a chest tube. And you find this out because you called your friend, a data manager across town, and you obtain this information. Do you go back and code it on your case, the pleural effusion requiring drainage? The answer is yes, the pleural effusion was drained, and it occurred during this patient's episode of care. Next slide. The patient remains on milrinone for 10 days post-operatively, and this milrinone dose is at greater than 10% than they were on at baseline when they came to the unit. So do you code the complication of cardiac dysfunction? Well, this depends. So you would code yes if the patient remained on this inotrope or milrinone due to cardiac dysfunction with low cardiac output. If they remained on the milrinone and they had normal cardiac function, then we would code no. So again, you need to work with your intensivists or surgeons to find out why the patient remained on milrinone or why a new inotrope was started. Next. Patient returns from the OR on milrinone. An hour later, the patient experiences profound hypotension, tachycardia, and acidosis. This resolved with multiple fluid boluses and the initiation of an epinephrine infusion. The doctor dictates that the patient had vasoplesio, the physician may have as well, with adequate cardiac function. So do we code the complication of cardiac dysfunction? The answer here is no, because the physician documented that the patient did not experience cardiac dysfunction. So yes, they had a low output state, but they had adequate cardiac function. Next slide. Patient with a preoperative history of an arrhythmia controlled with oral amiodarone. Postoperatively, the patient experiences an arrhythmia and is started on an amiodarone infusion. So do you code the complication of arrhythmia requiring drug therapy? And we get this question a lot because the patient has this pre-op history where they're treated with an oral antiarrhythmic. And so the point here is, yes, this is an event that occurred and the patient did experience this arrhythmia and it was treated with a drug or medication and it occurred during the episode of care. So this is something that we would code. Next. Okay, so moving away from complications and just looking at a couple of other FAQs that have been submitted, or I think just ongoing dialogue amongst the data managers. How much data do we complete when a procedure is canceled before skin incision? And so I know this can be tricky. We do want these cases to get into the database and of course make it past the thresholds of IQVIA without creating a ton of any critical errors. So there are some pieces that you do need to have filled out. So of course you need the patient's diagnosis and the procedure, which the primary procedure here is going to be that it was canceled before skin incision. You need an operation type, which is going to be other. And then we'd also like you to fill out your preoperative factors. This way, if anybody ever wanted to go back and look at the state of the patient when they entered the OR, we have a little bit more information perhaps as to why a procedure was canceled. And so that would be at a minimum of what you need to fill out for these cases. Obviously, you're not going to have complications or anesthesia information or much there to enter. So how to capture pulmonary hypertension preoperatively. So we know that many people are putting it under their pre-op factors other and typing it in there. Obviously, you can use those other fields for however you desire. Just know that it doesn't get included in the analysis. So there's no way that STS is really seeing what you're writing there, but for local use, you know what your other preoperative factors are. But you can include pulmonary hypertension preoperatively as one of your surgical diagnoses. And so there are 4 codes available in the database, all with their own definitions under pulmonary vascular obstructive disease. And I've listed the diagnostic codes here. If you have specific patient scenarios and you're trying to figure out which of these codes to use, please and you're unsure, then please feel free to submit a question and see which one of these codes best meets that. You can also work with your surgeons and or intensivists, cardiologists, to look at these diagnoses and see where your patient falls as well. Next. Okay, and to finish up, how to code the diagnoses. And I think this has been an ongoing topic. I consider this somewhat the art and science of being a data manager. And I think that this is difficult and probably will bring more discussion and perhaps questions, but that's okay. So defined indicate all diagnoses noted at the time of the surgical procedure or documented by preoperative studies. This entry may duplicate the fundamental diagnosis. So essentially what we need to code is the primary diagnosis, any other diagnoses that are present, your status post diagnoses, and your fundamental diagnoses. Depending on your software, everybody handles where the fundamental diagnosis is a little bit differently. Mine actually lives on a different tab. So I always include my fundamental diagnosis in my diagnosis list because it gives me kind of the full patient picture when I'm looking at the case. Next slide. So if we go through a scenario, I think it helps illustrate this. So you have a patient with TET pulmonary stenosis, underwent a previous TET repair, PDA ligation, ASD patch closure. today presents with pulmonary insufficiency, and the surgical plan is to replace the pulmonary valve with a homograft. So fundamentally, this patient is TET pulmonary stenosis, and that will remain their lifelong diagnosis. Their primary diagnosis, or the reason they're coming to the OR today, is for their pulmonary insufficiency. Do they have any other diagnoses? No, but status post, we have the ASD repair patch, the PDA closure surgical. Now, I know many of you under the other diagnoses would list also the ASD and the PDA there. Again, art and science, what do you like to look at in your program? You know, when you look at STS, doing it this way, exactly what's on the slide, will meet the what's required for analysis. So you're meeting, you know, what the STS database needs to do an appropriate analysis. I know for me locally, when I look at my data, if I had also listed an ASD and a PDA, I would presume that that patient had those lesions currently today walking into the OR. And I would think, well, why didn't we repair then that ASD or that PDA? And so I like to keep mine, I don't want to say clean because I don't think it's dirty if you don't, but I like to keep it cleaner that I can exactly see what is an ongoing problem today with my patient, or perhaps what is still a defect that is going to be unrepaired. That's fine. And I can keep anything that's been repaired under the status post diagnoses. So next slide, we can look at another example. Patient with heterotaxy, a right atrial isomerism, complete unbalanced AV canal, PDA, and aortic arch hypoplasia. The patient undergoes an initial aortic arch reconstruction with PA banding and a PDA ligation. Due to an increasing arch gradient and severe common AV valve regurgitation, the patient returns for a DKS, Glenn, and common AV valvuloplasty. So now what do we do? So fundamentally, this patient is single ventricle heterotaxy. The reason they're coming to the OR today is different than what they went to the OR initially. So today is for this common AV valve insufficiency, or depending on how severe the arch gradient is, you may choose that. I know this is based on a patient in my facility, so I know it's common AV valve insufficiency that brought the patient into the OR. But my other diagnoses that I would include are the things that the patient has going on at the time of surgery. So I know that there's an arch gradient, so the aortic arch hypoplasia, and I know that the patient is a single ventricle unbalanced AV canal. And so that's what I would have in my diagnosis list. Under my status post diagnoses, I would have the previous arch repair, the PA banding, the PDA closure. And so again, moving the things that have been repaired down under status post, because I don't want the PDA to show back up in the list as it's in, you know, it would, to me, looking at this, look like the PDA was unrepaired. And so that is how I do my diagnoses. Does anyone else want to speak to this? Does anyone else have any other ideas? Dr. Jacobs, I see you joined the call.
Yeah, I think you explained it exactly right. Both of the approaches that you described are fair options.
Any thoughts on those programs that would keep, say, the ASD repair or the PDA, or not the ASD repair, but the ASD lesion itself or the PDA lesion itself in their active diagnoses list?
Yeah, I mean, the way I would recommend doing it is having that coded, if it's repaired, having it coded as a status post diagnosis because it's status post repaired. Because when I look at those lists, I think that the actual diagnoses on the list are the diagnosis that the patient has at the time the patient's going into the operating room. And the ones that have previously been repaired or palliated would be covered with a status post diagnosis. That's why we added the status post diagnoses in the first place.
Perfect. Great. That's all I have. So I think at the end
Did I get that right?
I think so.
I agree with you too.
That's
Good
good.
job.
You get it. Chastity,
You get an A for the day.
Hey, Chastity, that was a great presentation. Really well done.
Thank you.
That was thank you, Tess. Thank you, Dr. Jacobs. That was an excellent presentation. I see we've got some questions. I'm going to run through the rest of these slides real quick, and IQVIA is going to give their update. So I'm going to turn things over to Joe, and then we can tackle these questions. Chastity, I know you need a moment to catch your breath. So we're going to cover the IQVIA update, and then we'll finish up, and then we'll turn things over to questions. All right, Joe. The floor is yours.
Great, thanks, Leanne, and thank you, Chastity. Good afternoon, everybody. Just a few updates from IQVIA today. Some known issues that will be resolved in an upcoming release. In regard to the missing variable report, STS 6892, the MVR is currently flagging data elements as missing, even when the demographics form version is prior to when those variables were added. So we will be adjusting the report logic to correctly take into account the demographics form version so that these variables are not flagged incorrectly. STS 7282, the anesthesia adverse event update to the calculation will be added to the MVR report calculation. So that currently isn't being flagged when it should be. And so we are working to update the MVR to capture that when it should. Similarly, STS 7271, the COVID-19 variables, temp code and temp date, and the hematocrit prior to circulatory arrest or cerebral perfusion. That's the HCT pri circ A variable. Those will be added to the missing variable report calculation as well. All right, a couple updates for the primary procedure report, STS 7126. The primary procedure mismatch report exception rule 1 is currently being ignored and using the general rule, resulting in the VSD repairs being displayed as the recommended primary procedure. So that is something we are aware of and working to correct in our next update. And then STS 7240, exception rule related to codes 1280 and 1660. Those exceptions are not being properly recognized either, so we are going to get that corrected as well. On the last side, just kind of summarize, these 4 items are the ones that the missing variable report is currently not reflecting correctly. And as mentioned previously in STS 7282 and STS 7271, those will be corrected and added to the report in an upcoming release.
Great. Thanks so much, Joe.
Usual reminders, if you have submitted a ticket and would like an update, feel free to reach out to us. And we are currently reviewing additional items to bring to your attention for our next call.
Great. Thanks so much, Joe. All right. Our typical ending slides here, IQVIA support plan. Again, just please include that participant ID number when you contact both STS and IQVIA. Greatly appreciated and helps us work our way through those questions and tickets more efficiently. List of resources that are available to you out on the STS website, the STS National Database webpage. From there, you've got a wealth of resources available to you. As always, if you can't locate the information that you're looking for, please feel free to just shoot me an email directly and I can get you to the information. Speaking of my contact information, I'm pretty sure you guys all have this memorized. My direct email, ljones@sts.org, and my direct line. For any database operational questions, please email Jane and her team at stsdb@sts.org. If you have questions related to STS public reporting, please contact Sydney Clinton. She can handle all things public reporting. Sydney can be reached directly at sclinton@sts.org, and that's S as in Sam, Clinton, CLINTON @sts.org. Upcoming congenital webinars. Our next user group call is scheduled October the 5th at 11:45 a.m. Central Time. I need to check the time on that. I need to confirm that. And our next monthly webinar is October 21st at 12 p.m. Central. So let me confirm the time on that user group call. I don't know if I have that right. So while I'm checking on that, let's go ahead and turn things over to you all for our questions. I think most of these are all for you, Chastity. So let's go ahead and get started. Did you want to read the questions, Chastity, or do you want me to read them? It's completely up to you.
I can read them, is absolutely fine.
Okay.
So question 1, when a patient has multiple OR trips for serial procedures, how to code blood transfusion for first trip and subsequent trips. I'm going to have you submit this as an FAQ so that I can send it over to anesthesia to answer this question. I think these have been ongoing questions that the data managers have had, and this really falls under Dr. Wiener and his team. And so if you would submit that question over to there, we'll get it answered for you. Next question is, can you explain the complication definition of assigning complication to the operation that's most closely associated with the complication. Should all complications go to the index operation? So Liz, to explain this, years ago, we could only put all the complications on the index operation. I think locally, many people that utilize their data very heavily locally wanted to be able to separate that out, especially if you had multiple, maybe very complex procedures and patients that stayed in-house between them. And so people wanted to be able to assign the complications to the appropriate procedure. Now, upon analysis, all of them do go to the index operation, no matter where you put those complications. So, upon analysis, DCRI picks all of those up and puts them back to the index operation. So you're welcome to do that within your data locally, or you can, locally define the operation where the complications are most likely associated with. And so I think that's a decision that you can make locally, knowing that everything will go to the index operation upon analysis. All right, so next, regarding arrhythmias, what if it's a surgery without bypass? So if you're in the OR and have arrhythmias and there are no bypass cannulas, then you would answer the arrhythmia questions as they occur. So if there was a drug that was given during the OR, absolutely, that you would go ahead and code that medication. It would be easy if we exclude any arrhythmia observed in the OR and concentrate on arrhythmias in the ICU. Dr. Jacobs, do you want to field that question or have any response to collecting the arrhythmias in the OR then?
He's on mute. I don't know if he had to step away.
Okay, he may have stepped away.
Oh, yeah, no,
okay.
I'm here. I was
Okay.
just sitting here talking on mute. I do agree that it would be easier to exclude any arrhythmia observed in the OR and just concentrate on arrhythmias outside the OR, but there's a reason that we do want to capture some arrhythmias that occur in the operating room. So as Chastity said before, any arrhythmia that occurs while the bypass cannulas are still in is we basically view as part of doing business and part of open heart surgery. But if a patient is in the operating room and the skin is being closed, and while the skin is being closed, the patient goes into ventricular fibrillation, that is a complication. That's not part of routine doing business. So we about 5 years ago had a lot of meetings with John Meyer and other leaders of the database to try to figure out what's a precise timing that we could say that it would actually be considered a complication. And that's how we came up with the definition that we have. And that's why we capture a subset of arrhythmias that occur in the operating room. Similarly, if one is doing an off bypass procedure on the heart and the heart goes into fibrillation, that's a complication. I hope that helps.
It helps me.
Did I do okay, Chastity?
I think you did okay. You're still working on your A for the day.
Outstanding. Outstanding.
I
think I owe you some orange Gatorade.
Yes, exactly. You're earning some today. Yeah. What about status post TOF repair? And I apologize if I left that off my example. There likely should have been a previous TOF repair. You're absolutely correct. And we will update that slide before we post these. So I apologize if I left something off in the repairs. Let's see, what is the purpose or advantage of capturing procedures that are canceled prior to skin incision so that I can communicate this to our surgeons? Our surgeons capture their own surgeries, and I suspect they're not taking into consideration entering the ones that are canceled, but I'd have to take a closer look at the database. I think here, Vera, and I'll let Dr. Jacobs weigh in as well, but I think that we're looking at those patients that entered the OR and then the cases were canceled. So not just anybody that falls off your surgical list, but the ones that hit the OR and then for whatever reason the procedure is not done either before or after skin incision. Dr. Jacobs, do you have anything else to add?
I think you answered that perfect.
Okay. Next, Angie, if the patient is still in the OR, chest is open, separated, totally off bypass, arrhythmia occurs, pacing or drug required, code or not code? I'm assuming you're saying code the complication or not code the complication, not cardiac arrest code. So arrhythmia occurs, pacing or drug required, separated, totally off bypass. So I believe for Pacing, the pacing still needs to be present when they exit the OR and enter wherever they're going, the floor of the ICU. And drug required, I think if they're completely separated from bypass and haven't left the OR, you would still code the drug. Beth, just want to thank Chastity for helpful education and for efficiently responding to my email question earlier in the week. So helpful. Thank you, Beth. Kelly, can you explain a little more why you would code a complication of arrhythmia before skin incision occurs? So we're capturing the intraoperative complications. So intraoperative meaning the patient came into the OR. And so yes, anesthesia is inducing the patient and putting in lines and things like that. And we are capturing things that then happen to the patient intraoperatively. And you would also capture them in the anesthesia portion if you're doing that database as well. Can you please show the first slide with the cardiac dysfunction scenario?
Yeah, sorry, that's why I have the slides the way I do. I was looking for.
Oh, okay. Yep. We'll get that shown.
I was trying, I think it's slide 18, correct?
I think, yes, 17 maybe.
17, let's go there.
Is that what you're looking for, Meg?
I don't know.
Or is it, I don't know which one's on 15. I don't know what order I did them all in.
Yeah, I think it's either 17 or 18, but
Okay.
I'll flip through.
All right. Without specific documentation from the surgeon or other physician that the patient has cardiac dysfunction, are there parameters that the data manager could use to determine if the patient does have cardiac dysfunction? Maggie, great question. I think that that can be difficult to pull out of a written document if people aren't good documenters or aren't giving adequate documentation. It's easy to find all the clinical signs and symptoms that are listed in the definition, but not if the patient does or doesn't have cardiac dysfunction. And so I think the best thing to do would be you're going to have to work with your clinical teams to get them to document better whether there is or isn't cardiac dysfunction. I found that if I send
Look at the echocardiogram.
Well, or the echo, yes.
It's highly unlikely that a postoperative cardiac surgical patient will have cardiac dysfunction and not get an echo that documents cardiac dysfunction. It's possible, but almost always, if a patient has hypotension after heart surgery, they're going to get an echo. And the echo is either going to say normal cardiac function or depressed cardiac function, mild, moderate, or severe. So if there's hypotension associated with cardiac dysfunction, then you've got it.
Yes. I think too, Maggie, if I send the same email on every patient that had surgery this week to the intensivists or surgeons, and I say, I cannot discern the difference between this and this, it's amazing that next week they'll start documenting that on every patient. So sometimes it's the persistence that pays off to get to what, you might need documented as well. Igor, but wow. This patient will have treatment in ICU anyway? I don't know what that's.
I think it was just following up on one of his earlier questions, or
okay.
Perhaps the arrhythmia observed in the OR, maybe.
Okay. Maggie asked a reduced ejection fraction from a pre-op or wall dysfunction. Is this speaking to the echo where you're trying to discern if there's cardiac dysfunction?
Maggie, if you want, I can unmute you if you'd rather just talk.
Yeah, would you rather speak, Maggie?
Okay, hold on. Coming. Okay, yep, hold on. Okay, Maggie, you should be unmuted. There you go.
So speak like a little puppy. So in relation to the postoperative echo, that to discern, cardiac dysfunction that's resulting in the low cardiac output state, a change in EF from the pre-op echo or new, wall motion abnormalities, that type of thing?
I think if the echo says ventricular dysfunction and the patient has low cardiac output syndrome, then it meets the requirements of the diagnosis.
Okay. Does it need to be different from pre-op or just that they have dysfunction?
It's a combination of ventricular dysfunction and low cardiac output. That's all.
Okay. All right. Thanks a lot.
You bet. Thank you.
So I have up the corrected slide somebody had asked. So my apologies. The user group call on the 5th is at 12 o'clock Central. So I had the incorrect times stated as 11:45. So I apologize. But again, the user group call on the 5th is at 12 p.m. Central, and then the monthly webinar is October 21st at 12 p.m. Central. So I apologize for the confusion there, but that has been corrected. I am currently not seeing any other questions come in. I didn't know if anyone had anything that you wanted to touch on before we end today's call. Looks like we've got about 7 minutes left in the hour, but just wanted to give anyone the opportunity if there was anything anyone wanted to add that we may have missed from the panelist side.
Haley Ann, did you say earlier, and I'm asking because I've had a lot of people ask me this, did you say earlier that the single 2021 harvest will contain cases through June 30th, 2021?
Yeah, so we are, because the task force is still, we haven't decided yet on the actual reporting period, but, my understanding is, for the 2020 harvest, we used the reporting period up through June 30th of, 2020. So I think it's, either way, it's the spring and fall. We're combining both of them. So everyone should, I would, encourage everyone to submit data up through 6/30/2021 and continue to clean that data.
Perfect. That's what I thought too. And I just wanted to make sure. I think that makes good sense. Thank you.
Right. All right. Beth. Sorry if I missed this, but when will today's webinar be posted? So after this, after the webinar ends, we'll get the recording. We'll send that over to marketing, and our awesome marketing team has to go through and work their magic and get it prepped and ready for posting in YouTube. So once the team is able to do that, it usually takes about 1 to 2 business days for them to get the webinar all wrapped up, packaged, and posted on the posted online. So give us probably until Friday or Monday. I don't know exactly what all Armando has on his plate today. So if I would give at least until Monday, please. But please, you feel free to check the website tomorrow, but I would probably think it may be at least until Monday before the webinar is posted. Okay. I'm not seeing any additional questions. Chastity, thank you for an awesome presentation.
Yeah, very well done, Chastity, and nice job, Leanne and Carol.
Thank you very much.
Thanks for joining.
I just played the music, Dr. Jacobs. Leanne and Chastity did all the work.
You did really, really good. Next time I suggest some Rolling Stones, get some Mick Jagger on the call.
Oh, I'm on it. Don't you worry about that.
Yeah, we're taking requests for music, so just let us know if you have any special requests.
Outstanding.
So thanks everyone for joining today. I greatly appreciate it. I hope you guys have a great rest of the week and a great weekend. As always, if you need anything, please feel free to email or call. I appreciate it. So thank you everyone, and I hope you guys have a great weekend.
Great job.
Thanks everyone.
Thank you. Bye.
Thank you.